GCA-PMR alumni, residents, staff, and students who are gathered here to attend this lecture by our distinguished guest professor, Professor Bhaskar Dasgupta. I also now request our Honorable former Director, Dr. R.P. Swaminathan, to come to the stage, please. May I also request Professor Bhaskar Dasgupta, our guest speaker, to the stage, please. I further invite Professor Reena, Professor of Pediatrics, and Professor Vaibhav, Professor of Neurology, to chair the session, please. I request Dr. Molly to kindly introduce our guest speaker.
Finally, the moment has arrived. We've been preparing for this meeting now for the past 1.5 months. I really don't know what I was thinking when I planned this meeting, because Professor Bhaskar was really keen to interact with all the faculty also, because he's a GCA-PMR alumni. And the fact that he loves his alma mater is evident from the fact that when I emailed sir about in the beginning of March, I said, sir, please teach us POCRUS. Within 10 minutes, the reply came. It'll be an absolute pleasure to visit GCA-PMR. Tell me the dates. Then I got like stunned and there's no time to plan. And sir had his calendar full entire year. So April was like a free-ish month for sir, because even after this meeting, he has to attend the BSR. Then afterwards, another series of workshops all over Europe. And then sir has got workshops also in ULAR. So basically a really busy person, and for sir to come forward and spend some time with us here in the institution really speaks for his love and dedication towards his home country and towards GCA-PMR, his alma mater. Probably for most of us who are in the rheumatology community, sir does not need an introduction. His work is evident. I mean, whenever you search a paper on giant cell arthritis or in polymyalgia rheumatica, you open any good quality publication, you'll always find Bhaskar Dasgupta. So it's like he is really a giant in the field of giant cell arthritis and polymyalgia rheumatica. I have put up Sir's CV here in just to tell you in brief, and all of you have also, I think, seen his impressive work, which I have circulated in the flyer. So, but one thing which is very more important to note is that because of his deep dedication and he's dedicated almost his entire life to the work for people with GCA and PMR, this work is so profound and impactful, such that he has received one of the highest honors that the British government can give in the form of an MBE. And I had to Google actually what MBE means. Probably it's one of those awards which is similar to Padma Vibhushan or something, which is corresponding to that kind of award which we get in India. So MBE stands for Member of the British Empire. Am I right, sir? So you can expand on that further, because we are not familiar with the British terminology. So, but without wasting much time, I would like to invite sir. And just a small note on the dais, you see Professor Swaminathan, RP sir. Sir is so gracious in that when I went to when I texted him first, sir, can you kindly come and be with us for this talk? The answer was instantly yes. Okay, I will come. That again gave another inspiration to me, you know, to conduct this faculty lecture. And I'm also grateful to Vaibhav, my dear friend, and Reena ma'am, who without hesitation, you know, has agreed to come to this meeting. Without further wasting much time, I think we'll now proceed with the felicitation of Professor Bhaskar Dasgupta, sir. I request RP to kindly come forward, Reena ma'am also, and Dr. Bhaeva, to kindly hand over a shawl and a memento to sir. So I think we'll proceed straight to the lecture and hear it from sir himself, all the work that has been done. Specifically, he'll be talking about ultrasound. Sir, please, the stage is all yours.
Dear Molly, and really I would extend my grateful thanks to all of you, the eminent members of the faculty in GCA-PMR, and all the juniors as well. And it exactly is as Molly stated it. She requested me to come to GCA-PMR, and I accepted within 5 seconds. Really, I'm instead of talking to you about what is publicized today, I could actually just fill the hour just talking to you about my reminiscences and my experiences in the time that I spent in GCA-PMR, not only in studies, but lots of extracurricular activities, music, dramatic, sports, everything. And really, I could talk to you for over an hour. I tell my children that the happiest hours, happiest years of my life have been spent in this institution. So it is a great sense of gratitude for me to come and address you today. So I will now move on to essentially what is billed today. Really, I'm going to talk to you about a little bit about my own journey in developing what we have done. I come from, just like GCA-PMR has a very special place in my heart. You know, people are formed from their academic institutions, and I would like to place that credit in with my school, the Loyola School in Jamshedpur, where I trained. And really, they had this obsession that it was not only enough to be a great, performer of distinction in science, humanities, and developing all-round personality. And this is something that I cherish and I try and inculcate in my juniors. So, and these are my academic background. So I spent time at GCA-PMR, and then I did my post-graduation from the All India Institute. And I will now come to you to why I concentrated on what I like to call now the spectrum disorder, the GCA-PMR spectrum disease, and possibly that includes Takayasu's now. You know, that is a very famous painting that hangs in the Pompidou Museum in Paris. It's a painting by Robert Delaunay, and really it's all about discs and intertwining discs. And that is when I started wondering about these conditions, when I was a junior research fellow training at Guy's Hospital under Professor Panay, that really what we like to club as separate diseases, GCA, PMR, Takasu's. Actually, I don't understand that anymore because there's so much of overlap, exactly as Robert Delaunay paints in that beautiful painting of his. So what we tried to do over my own lifetime, and I have the privilege of trying to bring some sort of order into this disorder. We really started with the laboratory science, and essentially I had the privilege of describing the first report of interleukin-6 elevation in any vasculitides, then we developed the guidelines for the British Society guidelines for GCA, for PMR, and we went on to develop the ACR-EULAR guidelines for these conditions. And we particularly took a lot of satisfaction when we developed the fast track pathway for GCA. Many of you know that the one disgraceful badge of GCA is irreversible permanent sight loss. And really, people become suicidal. It's the commonest cause of acute sight loss without injury. And we developed the fast track pathway to try and prevent the stroke in the eye. And it's now the de-rigor, the default mode for any sort of GCA service. And I've had great privilege. We described interleukin-6 back in the 1980s. And when it came to 2017, we were the first to describe the treatment of GCA using anti-IL-6 blockade using tocilizumab, which is now standard practice. And a year before last, we had another paper in the New England Journal where we showed that IL-6 blockade with sarilumab is actually very effective in polymyalgia rheumatica and approved for use in the USA. And now we are working on the spectrum, which I'm going to talk to you a bit more about, and also the concept of POCRUS, point of care rheumatology ultrasound. So this is a JIPMA meeting, and really I have great fondness because I presented a lot of what I'm going to talk to you about today at the JIPMA alumni meeting in the United Kingdom, and really the GCA spectrum. And we talked about the classification criteria, and we have the whole, all the JIPMA alumni who are based in the UK having a more relaxed social evening after a very packed morning of academic science. So Molly asked me, Dr. Taba asked me to talk to you about guidelines and what we do to develop the guidelines. And it's not an easy task. And really, we talked about most important for any sort of guideline is we need to identify the patient perspective. You need to develop the PICO questions. Those of you who are not aware of what a PICO is, we'll talk about that. Identify important outcomes. So whenever you are developing guidelines, you need to have these three very important aspects in mind. And in fact, using the patient perspectives, we developed a charity. It still is the sole charity in the world dedicated to GCA and PMR. That's called PMR GCA UK, and I'm having a Zoom Teams call with them later this evening to talk about some of the stuff that AI can be used for marshalling its resources for a diagnosis of this condition. So, in the guidelines, the most important was we developed certain set of what's called PICO questions. PICO stands for population, I stands for intervention, C is comparator or control, and O stands for outcome. So according to the guidelines you're developing, you have different populations. So it could be GCA, it could be PMR, it could be Takayasu's, or any other condition in the world. And then you look at the intervention, and that could be a diagnostic intervention, that could be a therapeutic intervention, it could be a prognostic intervention. And you look at people who are the controls, and then you look at the outcomes, which are the critical outcomes in the individual conditions. So, and we developed the PICO questions for PMR for the ACR-EULAR guidelines, looking at, for example, NSAIDs versus glucocorticoids, the dose of therapy, the duration of therapy, looking at intramuscular glucocorticoids, looking at non-biological DMARDs, looking at biological DMARDs, and all that was then enshrined in the guidelines. And then we looked at the prognostic factors, and this is standard. Whenever you're developing guidelines in any condition, that's what you need to do. You need to look at the prognostic factors. And what I nowadays mention to all my rheumatology colleagues, that we need to become like oncologists. I mean, oncologists, you see, they don't actually give a patient a standard treatment and then say, okay, now you take the standard treatment, go away. If your cancer relapses, I will give you some additional treatment. How silly is that? But that is what we do in rheumatology. So what we need to become is as smart as the oncologists. We need to stratify the disease. That's what they do. When they see a patient with cancer, they work out what is the staging, what is the grading, what's the histology, and then only then they choose the appropriate treatment. And in rheumatology, we are trying to do that. And we therefore need to use prognostic factors, we need to use clinical assessments, we need to use imaging. And that's why I'm talking to you about how important imaging is today. And we are running the workshop in the next 2 or 3 days. So we need to look at the prognostic factors. What are the factors that go with a high severity of the disease? What are the factors that go with lower severity of the disease and better outcomes, etc.? And we looked at all these factors in relation to PMR and with GCA and the comorbidities. So guidelines have to be suited to individual patients. And you need to have patient-specific factors that includes their age, their demographics, the comorbidities, the co-medications, the patient choice, and all that then goes into choosing what is the appropriate treatment for that individual patient. So I was asked to talk to you about guidelines, and these are the various outcomes that we look at in our area in GCA and PMR, the disease remission, relapses, refractoriness, duration of glucocorticoid therapy, etc. And all this is, I know we have lots of other physicians here and surgeons. All these are actually very important to all of us in different specialties. So these are the areas that we looked at for the development of the guidelines. And, we did detailed literature search. So for guidelines, you need dedicated juniors. And you need dedicated juniors who would say, okay, I'm going to sacrifice my sleep. I'm going to have systematic literature review, because it's very difficult, because that's the basis for the evidence for the guidelines. So we did really detailed literature search according to inclusion-exclusion criteria, and look at the number of papers that we had to go through to try and get the evidence-based. and we graded the quality of these papers. Now, the big problem that I tell particularly a lot of my Indian colleagues and others as well, is that it's not the quantity of your papers, it's the quality of your papers. And those are the things that determine whether your paper is actually going to go into the development of the guideline. So it has to be high quality. And there are certain criteria by which we can actually allocate criteria. For example, in RCTs, we look at, it's not that every randomized controlled trial is fantastic, because you have to look at whether blinding has been preserved, whether there's attrition, whether the outcomes have been properly assessed, etc., whether there's inconsistency, indirectness, imprecision in measuring your outcome. So all these factors we take into account when we say RCT is fantastic or it is rubbish. And publication bias. So people tend to have positive outcomes in their papers because editors like them. Editors don't like negative papers. So we looked at all that in developing the guidelines and the evidence base for that. And of course, you need to then borrow from other papers and other safety aspects of treatments, etc., before we came up. So we developed the guidelines for GCA along those lines, and we revised them 10 years later to update them. And that's another important aspect of a guideline. You need to update it because medicine is constantly progressing. And now, actually, if we were to develop these guidelines, we would no longer have separate guidelines for PMR, GCA, and probably include Takayasu's as well. We are talking about a spectrum. And what particularly brings all this very close to heart is that imaging. I was talking about that rheumatologists have to become a bit like oncologists. I mean, they can't treat cancer without imaging. And really, we are trying to do that with the use of ultrasound. And the fast track pathway that we published in 2015, which reduced sight loss, is based on a rapid diagnosis of GCA based on vascular ultrasound. And it was the first evidence of POCRUS altering outcomes. And, it allowed speedy referral to the specialist and the quick starting of the treatment for what I call the stroke in the eye. And all this is based on ultrasound. And in fact, actually, in rheumatology, that was the first basis for a national outstanding practice award using ultrasound for the treatment, early diagnosis of a condition. And of course, it was in GCA, we learned that, you see, clinicians on their own are not very effective. We have to have partnership with patients. And we developed the charity PMR GCA UK, and they've done outstanding work in progressing the awareness of this condition. Now I will talk to you a little bit about GPSD, and that is the spectrum. So GPSD stands for GCA-PMR spectrum disease. It's a bit like the Newton's explanation for the wavelength of monochromatic light, and you use a prism and you break it down into its different phenotypes. So within GPSD, we have PMR, we have GCA, we probably have Takayasu's within that. Because we now know that there are more similarities rather than differences between these individual conditions. And all these names, whether it be PMR, whether it's GCA, Takayasu's, they were all named 60, 70, 80, 100 years ago. Takayasu was named in 1908, and we now know actually there are more similarities between GCA and Takayasu's than differences. The only difference is we say that if it's under the age of 50 or 60, then it's Takayasu's. If it is above that, it's GCA. And now we're coming around to the whole concept of the similarities between the conditions. So we have now come across, we published this in several papers. We think that the clinical management of GCA and PMR should be driven by the awareness that they are closely interrelated conditions in a common inflammatory spectrum of diseases that can occur simultaneously or in temporal sequence to each other. And many conditions are, typically, like you have monochromatic light and you have the Vibgyor, all the other wavelengths inside monochromatic light. You have many different conditions within the spectrum disease. And there are lots of bases for considering it. They have the common characteristics like the interleukin-6 signature, the response to steroids, chronic relapsing course, and of course, all these conditions generally occur in the older population where the immunity has a different dysregulation that permits the emergence of these conditions. And there are loads of similarities in terms of imaging, in terms of the clustering of these individual cases. So we think at the moment that instead of considering them as separate conditions, we should be talking about separate phenotypes. And within the phenotype, you have cranial GCA, which occurs with headaches, scalp tenderness, visual symptoms, and typically associated with ultrasound changes in the temporal arteries. You have ischemic GCA phenotype, which occurs in the older population, generally in their late 70s, 80s, 90s. And these are patients, quite often, they don't present with headaches. They often present with jaw pain, scalp pain, jaw pain and tongue pain. And these patients, of course, are the ones who have the visual complications. And sometimes they have cerebrovascular complications, including strokes. So that's cranial and ischemic GCA. And you can see on imaging, of course, here I've chosen the fundoscopy picture of central retinal artery occlusion. And you can see the beautiful, not beautiful, horrible cherry red spot in the macula due to sparing in central retinal artery occlusion. And of course, the third phenotype that we see, which is the one that is very similar to Takayasu's, is a large vessel GCA. And here again, ultrasound really shows up all the abnormalities in the axillaries, the subclavians, the carotids, and most damningly in the aorta, which gets involved in this condition. And now we know that PMR, polymyalgia rheumatica, can be a phenotype of the spectrum diseases. And of course, PMR is typically associated with shoulder, hip girdle problems, and you get typical changes on imaging using the PET scan or using the ultrasound in patients with PMR. And we think that Takayasu's actually should now come into the spectrum. And I'm very pleased to note that we don't see that much Takayasu's in the UK, but people who do, such as in India, but also in Japan and in China and in Turkey, exponents, they feel that Takayasu's should be part of this spectrum. And this is the paper that we are, it's a review that we are writing, and it starts off with various different cases. And all these cases actually have a intermingling of polymyalgia, of cranial GCA, and ischemic GCA, et cetera, et cetera. And they suggest that actually there is a spectrum. If you look at the pathogenesis of these conditions, basically they have a common pathogenesis. There's disease initiation, disease amplification, and vascular injury. And these are actually gradations of the inflammatory response. So a patient who's got mainly one type of inflammation going on, they will have one phenotype. Someone with a balance between Th1 and Th17 will have another phenotype, and someone who's got primarily what's called Th1-directed inflammation, where you get vascular injury, they are the people who might get the ischemic GCA. So what I try and explain in my talks is all these conditions you can think of like the cars traveling on a motorway along different lanes. And in a motorway, you will find that there are slow cars on the near side lane, the medium speed vehicles on the middle lane, and the fast vehicles on the fast lane. And that is inflammation in real life. And that is what gives rise to the spectrum. So according to the velocity of the inflammation, you get the different phenotypes of these conditions. And the way we stratify them, and I think we should be doing that for most conditions. So you have a clinical assessment, you have an imaging assessment, and you have a laboratory biomarker assessment. Like, for example, again, what the oncologists use. And this is what we are trying to do, because all these different phenotypes are associated with different imaging manifestations. And so we need to couple clinical assessment with imaging assessment, and we are trying to develop a specific laboratory biomarkers that might differentiate between the different conditions. So therefore, what we need to do is use ultrasound, and ultrasound is so useful because there is no radiation. You can do it repeatedly in a patient. You can use it for diagnosis. You can use it for assessment, monitoring, and look at the prognostic implications of ultrasound. So you can stratify the patient into receiving the right treatment. And now I'm very pleased to note we no longer are dependent solely on steroids, and we have a panoply of DMARDs, biologics, and there are a large number of clinical trials going on in rheumatology, and the focus is on large vessel vasculitis. So exactly again, like the oncologist, we need to stratify the disease and then choose the right treatment. So, and that's where ultrasound comes in. And this is the whole scheme of POCRUS, or point of care rheumatology ultrasound. So we want to develop a spectrum score, a prediction tool within GCA-PMR TACASUS by combining a disease-specific probability score, and that's a clinical pre-test probability, and then you combine it with ultrasound. And for example, in GCA, we look at the halo count, the halo score, and in PMR, you look at PMR-specific changes. And TACASUS is very similar to what we would assess with large vessel GCA. So, and we are trying to do all that. And we have been very successful in using this combination of POCRUS in predicting a diagnosis of GCA. There's a paper that was published in Lancet Rheumatology last year, where we sequentially applied the South End GCA activity score, the South End GCAPs, to the ultrasound. And we found that the resultant, this is the South End probability score, and that's the ultrasound. And we found that the combination gave rise to, you see, this is the 8-vessel ultrasound that we did, and this is the typical change that we see on ultrasound. You can see that the vessel wall is inflamed, and you can see the blood flow is surrounded by a thickened vessel wall, and that gives rise to the halo. And you can look at that in the temporal arteries, you can look at that in the axillary arteries, carotids, subclavian, etc., and you can standardize it. So you can do what's called a halo count. And so once you've got your clinical probability of suspected GCA, it gives you the pretest probability of GCA. Then you do your ultrasound, and then you come up with what's called a post-test probability of GCA, and that's the has GCA score. And we are going to have workshops tomorrow to illustrate that on real-time patients. And that tells you, is GCA likely, is GCA unlikely, or GCA is uncertain. So that's your post-test probability. And in the uncertain group, you do further investigations. And this is something that we think that POCRUS is going to be of great use for us. So what we have done is, ultrasound previously was thought to be yes or no. Does it show this or does it not show it? And actually, in real life, it's not so simple, because there's a spectrum. And sometimes ultrasound is very strong in suggesting a particular condition. Sometimes the ultrasound is weak in suggesting the condition. And then there's a lot of variation in between. So it's like using, CRP. We all order CRPs every day in the clinic. What if the CRP result were to come back as positive or negative? That wouldn't be very helpful. So we are trying to do the same with ultrasound. We are trying to make it quantitative, standardized assessment, and you can quantitate it using halo count, halo score, and that gives you a better idea of the disease activity in patients with GCA. And you can actually, what's called the 8-vessel ultrasound that we do, which gives you that quantitative assessment. So then this is the soul of POCRUS. And here in POCRUS, what we have is at the top line, you have the pretest probability, low probability, intermediate, or high probability by your clinical probability score. And then you do your ultrasound and look at the specific or sensitive findings on ultrasound. And that gives you the post-test probability. For example, when you do the ultrasound and you have a high halo score or a high halo count, then you have a specific finding in the presence of compatible clinical probability, and you can say GCA is likely. But if you do a 8-vessel ultrasound and you find no halo, you see, and halo is very sensitive. That means absence of a halo has got very high negative predictive value. So if you have no halo on ultrasound, then you can say that GCA is unlikely. In the middle, you have a halo, but you have very low halo count and halo score. Then you say that GCA is uncertain. That's when we may need to do other investigations, including a temporal artery biopsy. So this is, again, the principle of POCRUS, combining a disease-specific probability score with ultrasound scores. This is the soul of the paper that we published in Lancet, and we came up with what's called the HAS-GCA score, and the HAS-GCA score performed very well in predicting whether the patient had GCA or did not have. So it's very simple. And I think that this is a principle that can be extended to lots of other conditions and other rheumatological conditions. So you do the south end GCAPs, and that gives you a certain value. and then you do your ultrasound, and then it gives you the halo count, and ultimately you combine that together, and that's your post-test probability of GCA. So that's your has GCA score. So and this is very important because we have done this in patients with PMR, labeled as PMR, but patients who have systemic symptoms, who have high inflammatory markers, and many of these patients actually have vasculitis when you look at it with ultrasound. And these patients do badly on steroids. They have very high relapse rates, and it's very important to pick them up. And this is a patient of mine who presented first with typical PMR symptoms, and we did ultrasound and had bicipital tenosynovitis and subacromial subdeltoid bursitis, and then developed synovitis, and finally developed large vessel vasculitis. As you can see in the subclavian artery on the axial scan, longitudinal scan, you can see the thickening and typical features of large vessel vasculitis. So what we now recommend is that all our patients with suspected large vessel vasculitis, we really need to look at their symptoms, whether they have polymyalgic symptoms or large vessel symptoms or cranial symptoms. We do ultrasound, and that gives, and the big thing about ultrasound is literally we can look at the entire vasculation. Ultrasound, we can repeat it when the patient comes to the clinic, and we can look at the cranial arteries, large vessels. All this is amenable to ultrasound examination. And we think that this is the way forward. We do not as yet have ultrasound very well done for ocular ischemia, but that's something that is in the pipeline. So I'm not going to go into the details, but we basically we talk about several cases where ultrasound gives you very good. This is the patient, 63-year-old man, and beautiful pictures. So he presented. He was a fit man, and he presented with systemic symptoms, and he had very odd visual symptoms, very suggestive of cortical occipital cortex involvement. He had visual hallucinations. He had, when he was writing something, the last words were disappearing. When he was watching television, the moving players, they were leaving a trail of images, and essentially he had posterior circulation strokes, cerebellum and right occiput and the posterior parietal lobe. And you can see that on the CTA, you can see the vertebral artery, how thickened it is compared to the opposite side. And the patient had, you can see the temporal artery halo, and the arrows there, that's the thickening. That's the thickening due to intimal hyperplasia of large vessel vasculitis, and it's involving the axillary arteries as well. So really, he presented first with polymyalgia and then with large vessel disease, but also he had ischemic disease. So we are talking about the different phenotypes that can exist in the same patient. This is a 41-year-old chap, and you would label him as, he came to me with typical polymyalgia. And I said, how can you get polymyalgia in a 41-year-old? So whenever I get young people with polymyalgic systemic symptoms, I always do a thorough ultrasound. And he had typical large vessel vasculitis. Basically, he has Takayasu. And you can see how good ultrasound is in picking up large vessel vasculitis. You can see the thickening. It's the machine that's done it. It's drawn the machine. The machine actually draws the lines of the intimal medial complex. And on your in the lower right-hand panel, what's called a slope sign. So, and the thickening of the artery and the intimal hyperplasia slopes off into the normal. And this is a 41-year-old chap who had a polymyalgic presentation of Takayasu's disease. And so this is the abstract that we are presenting at the EULAR, which suggests we've already got consensus that these conditions are not separate diseases, but there are phenotypes within a common spectrum. And so we are working on Takayasu's as well at the moment to bring Takayasu's into this spectrum. And one very, very important aspect, one commonality of all these conditions, they affect the aorta. And they affect particularly the ascending aorta, the aortic arch, and the thoracic aorta. Takayasu's, of course, in India, affects the abdominal aorta and the renal arteries, etc. But it's primarily, it's a aortic arch syndrome. And that's where we get GCA as well. And that's where we get PMR as well. And so we need to really concentrate on the common bad outcomes, and that's the aortic outcome. And really, I'll just tell you one case. This is a final 73-year-old lady presented with polymyalgia, presented with systemic symptoms, was treated with steroids. She had a PET scan that showed aortitis, but because she had improvement on steroids and a bit of methotrexate, she said, that's fine. I don't need to be followed up. And then when she came back to see me after 3-4 years, you can see the big aneurysms. You can see the aneurysm in the ascending aorta. You can see the big aneurysm in the descending aorta on the axial view and the longitudinal view. And only a very good cardiothoracic surgeon at St. Thomas's saved her life because she didn't have any other comorbidities. So he replaced everything. He replaced the ascending aorta, the aortic arch, descending aorta, and the patient lives to tell the tale. But we want to prevent this. And the way to prevent all this is by ultrasound. And this is specific, the echocardiography that you can use to look at the dimensions of the ascending aorta. Primarily the zone of echocardiographers, but increasingly rheumatologists. We are doing this as part of the large vessel examination to look at the ascending aorta. And again, patients with PMR, relapsing PMR, who can present with aortic arch syndrome and who have the typical large vessel stenosis. Here you can see the stenosis in the subclavian arteries. There's an occlusion on the left, and there's arthritis on the right. And we can pick all this up with ultrasound. So we think that ultrasound or point of care rheumatology ultrasound really should be used to stratify disease along with the clinical assessments to prevent the complications of aortitis. And we need to be specifically looking at the aorta in ultrasound. I think I might stop here. And really, I'm very happy to take in the next few minutes that are left some questions. We need good stratification because we need better drugs. And one drug that I'm very impressed with is leflunomide. It's completely generic, costs nothing, but I think it's highly effective, and we need to do randomized controlled trials. We are doing the ultrasound workshop here for the next couple of days, and I spend a lot of time across the globe running some of these ultrasound workshops, and we are doing one in the United Kingdom. And what I'm trying to bring in is all the other rheumatologists in different specific conditions, whether it be rheumatoid, whether it be systemic lupus, ANCA vasculitis, systemic sclerosis, or axial spondyloarthropathies, psoriatic arthritis. We need to develop a stratified approach. we need to, the way oncologists do things. And so these are my acknowledgements. You know, huge amount of work has gone into lots of my juniors who are very distinguished rheumatologists and researchers today in the world, some of them in India. Again, I will finish in my spare time. I do write poetry, really, this is a poem I wrote on a different occasion that is absolutely perfect for my lecture today. The name of the poem is Time Boating. Time Boating. A journey up this Spriti River. I don't have to explain to this audience what a Spriti River is. A journey up the Spriti River is not always an easy task. To relive the exhilarating nausea as the boat dives from crest to trough while we row against the flow of time. That's what I'm doing today. Yesterday, we were at that rock, we remember. But that gap between the woods where we saw the flash of the momentary sun sprayed by the torrent in kaleidoscope colors into our half-averted eyes. Was that the day before or only a lifetime ago? I really feel that I was studying at GCA-PMR just a day ago. Thank you very much.
Thank you, Dr. Dasgupta. It was a wonderful journey across the spectrum of GCA and PMA. And now, in olden days, we used to teach the undergraduate students as well as postgraduate students when there is a pulselessness with hypertension, Takayasu, you should always think of. And the olden days literature, if we search Dr. Sen lecture, as well as Sen papers on Takayasu arthritis from West Bengal, is supposed to be one of the leading article in those days. And after that, angiogram has become the time-tested thing to identify Takayasu arthritis, they were telling. Now the ultrasound. And in the angiographic findings, we used to see nodularity of the vessels and narrowing of the vessels and no collaterals. That was very specifically told by many teachers for me. And in comparison with coarctation of aorta. A coarctation of aorta, where a lot of collaterals will be there and pulselessness will be there. But here it is like that. Now we have gone beyond all these things, and then we are using ultrasound to pick up the large vessel disease. And I hope that ultrasound should be made as what is called as an extension of clinical examination in all the branches of medicine. And it has been in GCA-PMR, we thought that we also should be in pace with the world working. We were able to acquire a lot of ultrasound missions, and almost in all the floors they have ultrasound mission. I hope Molly will accept that every department has got ultrasound mission, and our ICU has got 2 ultrasound missions which are portable. I have a feeling that if you train our fellows the vascular ultrasound, I have a feeling that they will definitely use it at point of care to identify dreaded disease which can be treated easily with the leflunomide. Thank you so much for your nice pictures. Thank you.
Thank you very
for
much.
your lecture, sir.
Thanks a lot.
Yeah, anybody wants to ask a question, sir will be ready to answer to you people.
Perhaps a neurologist. That was good to ask. I mean,
so they say ultrasonography is now, as sir said, it is coming up everywhere. Even our basic books have also changed towards ultrasound. Like new President Shapiro has ultrasound correlation in that addition to the whole book. I wanted to ask you on this thing. Currently, the way I see it is working in 2 manners. One, where the point of care is available when the clinician can do it, and otherwise you have to refer to the radiologist and get it done. In both the scenarios, in these conditions, how frequently you need to monitor the condition, and if to send, how frequently to send, and if you have to do, how frequently you should do that?
Yeah, that's a very good point. I don't think that everyone should learn ultrasound. I think everyone should be aware of the benefit of ultrasound, and every department should have sonographers, whether it be clinicians or sonographers themselves, who can do the ultrasound, who work hand in hand with the clinicians, so that, for example, if you see a patient in the clinic, depending on the urgency, that patient could have the ultrasound the same day, or the same week, or the same month, depending on what your question is. I think your second question that you had was how frequently we should do it. Now, I would put the question back to you. It depends on the type of disease. And in mild disease, where it's very clear what to do, etc., you don't need to do too frequently. Whereas if your baseline stratification suggests that this is extensive disease, this is very severe intimal medial thickness, it is affecting some of the major critical blood vessels, it is affecting the aorta, then I would say that we really keep that patient under a microscope and follow them up with regular measurements every 3 months, 6 months, etc. So it depends on, we need to use clinical imaging baseline to stratify how frequently you follow these patients up and what treatment you choose. And I think we certainly, rheumatologists, we need to work very closely with neurologists, because the condition that I was talking about, half my referrals come from neurologists. I mean, that patient, that 63-year-old man, that was a referral from one of our very distinguished neurologists. Can I just sort of add, I have learned so much clinical medicine from India. You probably know Dr. Ahuja at AIMS, neurologist, and he taught me, he was the most amazing clinician. And, he used to say, he used to love me, and he'd say, Bhaskar, what is, you present this case, what is your clinical diagnosis? What is your anatomical diagnosis? What is your pathological diagnosis? I have taken those lessons. Today, what I was talking about is basically what we are trying to do is a clinical diagnosis, anatomical diagnosis, and a pathological diagnosis that allows you to treat the patient. And really, so it's very, very multidisciplinary. Thank you.
Sir, I would also like to ask a question. This way, sir. So thank you for a wonderful talk. Going away from the age group that we have been discussing, since I'm more interested in children younger than 18 years old, we see a lot of patients with Takayasu. I was wondering whether we can apply these guidelines, or so much work that has gone into it to children, at least the older ones. We see children as young as 9 years with Takayasu. So what would be your advice for us, sir?
Absolutely. We should be doing that. I mean, it's difficult to keep children still. And for ultrasound, you need that bit of compliance. But I don't think there'll be a problem. And I think the big advantage of ultrasound in children will be, which I've done, is that ultrasound is actually easy or difficult according to the proportion of subcutaneous fat. And it's a bit more difficult to interpret in slightly overweight adults. Whereas generally in children, you would find very little subcutaneous fat. Yeah, and I would think that actually ultrasound would be your procedure of choice to monitor these patients with childhood Takayasu.
It's go to investigation before doing a
I mean,
before intervention.
Yeah, CT, all the other interventions are, they involve CT, radiation, PET, the tracer uptake, whereas ultrasound can be used to monitor regularly. Either it's MR, you can use MR, but MR is not available in all centers, MRAs, and it's a bit more tricky. But ultrasound is brilliant. I mean, for the carotids, axillaries, subclavians, which are the ones that are really involved in TACAS. But in India, you would probably find a lot of abdominal aorta. But you can actually monitor with ultrasound the IMT in the abdominal aorta.
But we may need to do some studies because the sizes would be different, probably cutoff values will be different, sir.
So you should, this is where you can make a unique mark by initiating an ultrasound study in pediatric TACAS disease. You develop the age and sex-based, comparisons, and it'll be a brilliant paper in a top quality journal.
One more thing, sir. I mean, one patient you mentioned bursitis. I would like to know whether chronic bursitis may be a harbinger of changes.
So when because I didn't have much time, or I touched on many of these topics, which would individually be our lecture. So the bursitis that we see in PMR is different from the traditional mechanical bursitis. So we see the PMR inflammatory bursitis has to be bilateral. So we must see it on the right side, we must see it on the left side. And inflammatory bursitis, we then put the Doppler activity, and it lights up. Basically, it should have, power Doppler should show ideally grade 2 or above, but grade 1, if it is, it's quite widespread. So it has to be bilateral, and generally we like to see the vasculation. That is another big advantage of ultrasound. So you can use ultrasound with the color Doppler and the power Doppler to actually make an assessment of inflammatory disease.
Thank you so much, sir. Thanks a lot.
Thank you. Any other questions?
Thank you. Thanks indeed, Professor Bhaskar, for taking us in depth. A lot of your lecture was pregnant with meaning, especially. The question is, students are always told, if you don't know the answer in the present, the answer may be in the history. Or it's also possible that the maximum immune traffic occurs in the gut. So we are what we eat. So in that way, does the immune traffic in the gut has anything to do with this? Because that is another aspect of it. You are now looking at the diagnostic perspective, whereas a causative perspective will be both nature and nurture. So in that way, also there is a lot of work can be done. The moment you classify something, half the job is done. And I think you conveyed that so well, Bhaskar. Thanks indeed for
Thank you. And I must say that it's something that really, the microbiome and the gut flora, fauna, and autoimmune diseases, so much are diet related. So that is a huge, rich area for research. I don't think it's been explored in large vessel vasculitis.
Thank you.
Anybody else? Any student? Resident doctors who are doing DM or MD, general medicine? So the triggering point for the vasculitis in India in olden days, they used to tell mycobacterium tuberculosis for TACAS disease.
Yes.
Is it still holding good, or it is not holding good?
I think we always look for it. Truth be told, in outside India, in the West, etc., we don't find that strong association. And that's possibly because it's Takasu pathogenesis is multifactorial.
Yes.
But I'm sure that the mycobacterium would easily trigger off immune inflammation that leads to arthritis. As you said, nature versus nurture. So if you got bad genes, autoimmune genes, and on top of that, you develop a microbial insult like mycobacterial, then, and you in the right place, you will get large vessel vasculitis. There's certainly genetic models of large vessel vasculitis in mice, the valve C mice, depending on if they are grown in microbe-free conditions or versus normal conditions. One group develops vasculitis, the other group does not. So clearly there is evidence that microbes determine vascular inflammation. Exactly how they do it, exactly how much mycobacterium contributes to it, I don't know.
Was tuberculosis. Anything below the diaphragm was amoebiasis. Till H. pylori came. Then after that, anything below the diaphragm was H. pylori.
That's a classification. That's what I'm saying. It's all a spectrum.
Thank you so much, sir, for a wonderful lecture. Thank you so much.
Thank you.
It's been a wonderful hour. My sincere thanks to Professor Dasgupta, sir, and to everyone in the audience for your kind attention and for listening very patiently to this brilliant talk. My sincere gratitude goes to all the chairpersons. RP, sir, thank you so much for being here, for blessing us, and for being a source of inspiration always. Dr. Vaibhav, thank you so much. Marina, ma'am. And then I thank our esteemed director, Professor V.S. Negi, who could not come to be here because of series of meetings in the administration. And my dear colleagues in the Department of Medicine, thank you so much, all of you, for being present here. Dr. Subhashini, Nivedita, Dr. Shashirekha from OG, Pampa Madam, Dr. Rakhi Kar, Madhu, and all plastic surgery. And nonetheless, I will not forget Professor Mahadevan. Sir, thank you so much for being here. Venkat, thank you so much. And Professor Prakash Chand, sir, you really are a true warrior of JIPMER, sir. Just a single message was enough to make you to come here and to meet your senior Professor Bhaskar Dasgupta. So all the residents, I hope you learned something and that you'll be inclined now to take up rheumatology as a subspecialty when you finish, and all other residents from the other department. I can see Dr. Vinod here also in forensic medicine, Dr. Amit Kumar Dev. I think they're standing here to take all the faculty for the GFA election. So we have a GFA election right now going on. So without wasting further much time, I think we'll give a round of applause to Bhaskar sir. And before we leave, meaning we can exit the hall, let's have a cup of tea together, then we can depart. Thank you so much. Thank you.